Good morning, dear students. Today's lecture, methods and diagnostic criteria of the syndrome of the pulmonary tissue seal. The pulmonary tissue compaction syndrome means this is the appearance in the lung tissue airless areas due to inflammation or due to inflammatory or non-inflammatory reasons. And the pulmonary compaction syndrome is one of the most pronounced manifestations of pulmonary diseases, and we take into account that it consists in a significant reduction or complete disappearance of the airness of the lung tissue in a more or less common areas, so maybe segment, maybe proportion, simultaneously several parts. And we take into account foci of compaction depends on localization, which also has a different diagnostic value, especially allocates subpleural localization of the center of densification with the involvement of visceral and friendly parietal pleural sheaths, which is accompanied by the addition of signs of pleural syndrome. And the development of compaction can occur quite quickly, for instance, acute pneumonia or lung infarction, or can occur gradually, develop gradually due to swelling and due to atelectasis. The causes of syndrome of pleural tissue seal, they are different. We take into account pneumonia. This may be pleural infarction, not pleural, pulmonary infarction, may be due to pneumosclerosis or paraneoplastic processes, tumor, due to diffuse connective tissue disease or tuberculosis. And pathogenesis of development of this syndrome, it can be described in patients with pneumonia. The most frequent clinical case. The etiological factors, infection, they lead to decrease in airness of lung or its parts and patients, they have inflammation exudate. Inflammation exudate fills in the alveoli, and this inflammation exudate is rich in fibrin, and moreover, we can find out that uniform elements of the blood, they displace air in the alveoli. That's why the blood gas exchange becomes difficult or diminished. And or other example of pathogenesis of the same syndrome, pulmonary tissue seal syndrome, can be observed in other clinical condition, pathological condition in patients with thromboemboly of pulmonary artery. Etiological factors, they lead to decrease in airness of lung or its parts. But the etiology of lung infarction was the thromboemboly of pulmonary artery. Thromboemboly, the source of thromboemboly can be inferior veins from the low extremities, for instance, in thrombophlebitis. And as a result of thromboemboly of pulmonary artery or some branches of pulmonary artery, the alveoli are soaked with blood, then lead to inflammation. Other example of clinical example of manifestation of the same syndrome, lung compaction syndrome, can be patients with pneumosclerosis. In pneumosclerosis or large tumors, the airway lung tissue is displaced by airless tissue. For instance, in patients with pneumosclerosis. Pulmonary tissue compaction syndrome can be manifested in patients with syndrome of inflammation, for instance, pneumonia, or in patients with syndrome of pneumosclerosis, and due to fibrosis, proliferation of connective tissue in a particular area. And in patients with atelectasis syndrome, these are patients with lung collapse upon cessation of air access to the alveoli. Infiltrative lung syndrome, infiltrative lung tissue compaction syndrome is the penetration and accumulation of cellular elements, fluids, and chemicals into the lung tissue. And infiltration leads to increased lung tissue density. When we notice the differences of infiltrative compaction from pulmonary edema. In pulmonary edema, soaking is carried out only with biological fluids. Cellular elements are not involved. Infiltrative lung tissue syndrome in the lung appear different in size. There are airless sites, both inflammatory and non-inflammatory nature at rectalis. That's why we stratify pulmonary infiltration as inflammatory or paraneoplastic. Inflammatory pulmonary infiltration is typical for patients with pneumonia or patients with pulmonary tuberculosis, eosinophilic infiltration, systemic lupus erythematosus, fungal and parasitic diseases. Patients with tumors, they can have leukemia, cancer, or lung cancer. Also, we notice types of infiltrates morphologically. We stratify to group A inflammatory. These are, they have leukocytes, eosinophilic lymphoid, macrophage, hemorrhagic, etc. And second type, this is tumor. This is patients with tumors. Lung tissue still, we notice, depending on the size of the affected part, the compassion of the lung tissue may be lobar or focal in several segments. And lung consolidation, lobar or segmental, with shear segmental compaction, or maybe with lobar pneumonia, the entire lobe segment of the lung affected by inflammation, hyperallergic nature of inflammation. What about clinical symptoms of infiltrative compaction syndrome? Patients with the syndrome of infiltrative compaction, they usually complain of cough, dyspnea, chest pain, hemoptysis. And chest pain, we notice when the infiltration site is located on the periphery parts of lung and goes to pleura. And we notice clinical symptoms of infiltrative compaction syndrome. We highlight additional general inspection and additional complaint. At general inspection, we usually assess increased breathing, tachypnoea, lagging half of the chest on the affected side, cyanosis. As for additional complaints, we can find out fever, chills, headache, weakness, sweating. And at general inspection, we assess, we perform inspection, palpation, percussion, and auscultation. We use, of course, we use our skills, clinical skills, to and we perform auscultation with stethoscope, and also we need centimeter strip. Clinical symptoms. At palpation, we find out changes of voice jitter, Voice tremor over the affected part is usually enhanced due to compaction of the infiltrated pulmonary tissue that conducts sound well. Percussion is necessary for assessment of lung boundaries, and we perform comparative compaction in order to assess the assess the sound, and blunt sound, blunting. It's typical for it's typical for patients with pneumonia above the area of compaction in patients with pneumonia, but at initial stage or during a stage of resorption. Percussion, we perform topographic percussion and comparative percussion. The topographic percussion of the lungs is necessary in order to assess the boundaries of pulmonary sound. We assess the lung boundaries, and comparative percussion, we can find out shortening or blunting of this percussion sound the above involved area of lung. And we perform the auscultation. Auscultation, we assess the basic respiratory sounds. It is usually typical presence of bronchial respiration, and it is due to the homogeneous seal in zone between the large bronchus and the periphery of the lung. As for adverse respiratory sounds, we take into account crepitus, pleural friction sounds in patients with pleural pneumonia, and wet ringing wheezing. Bronchophony. Positive bronchophony is determined in patients with pneumonia. Diagnosis of infiltrative proportion seal. We usually notice central location of the mediastinum. It is usually not displaced, and lung tour reduced, strengthening voice jitter on the above the affected side. We notice dull percussion sound, bronchial respiration, strengthening bronchophonic crepitus, and we can find out wet, sonorous, or consonant wheezing, pleural friction noise. Focal seal. In case of drainage damage of the lobe or lung segment, a picture is observed that is different from the symptoms of lobar consolidation in Cropos pneumonia. Clinical of infiltrative focal seal. We usually use questionnaire during conversation with patients, and most of patients, they complain of cough, fever, subfebrile or moderately high dyspnea as a sign of respiratory failure. It is but the dyspnea is typical for patients with lobar pneumonia. Clinic of infiltrative focal seal. We perform percussion, and if there is enough extensive seal located close to surface of the chest over the affected site is detected dull percussion sounds. As for topographic percussion data depends on prevalence of lesions, and with a small seal plot may not change. Diagnosis of central pulmonary tissue seal, and we know that the credible sign of the syndrome is these are dull percussion sound, moist, sonorous, fine bubbling rails during auscultation, and bronchovesicular breath at auscultation. How about clinic of infiltrative focal seal? We perform auscultation, we can find out basic respiratory sounds, with local seals noted mixed bronchovesicular breathing. So how around the seal center is located normal lung tissue. And adverse, we can find out adverse respiratory sounds such as wet rails, dry and wet fine bubbles, and the inflammatory consolidation of the lung tissue around the bronchi facilitates the better passage of wet rails to the chest surface. And next instrumental test very useful for assessment this syndrome. This image is the plain chest X-ray of patient with pneumonia. We can see the homogeneous darkening of focal inflammations at least one. Подождите, через 10 минут. CT scan, computer tomography, CT scan. By the way, this is very helpful method of imaging of the lungs, and CT scan provides more accurate imagings. Infiltrative focal seals. These infiltrative focal seals, you can see multiple signs. We can see different clinical cases. For instance, patients with different locations of this syndrome. And this imaging provides radiological signs of non-specific pneumonia infiltration. We can see localization of pneumonia in different patients. This imaging of X-ray imaging of Mycoplasma pneumonia. Atelectasis. Atelectasis, also known as collapsed lung, this is a condition in which the airways and the air sacs in the lung collapse or do not expand properly. And a collapsed lung happens when air enters the pleural space. And it can be a total collapse. It leads to pneumothorax, or only part of the lung is affected, atelectasis. And the causes of collapsed lung include lung diseases such as pneumonia, lung cancer, mechanical ventilation, surgery of the chest or abdomen, a blocked airway, and symptoms. And by the way, the symptoms depends on area of affected lung. The most common test used to diagnose atelectasis, this is chest X-ray or CT. As for bronchoscopy or imaging tests, they can confirm a diagnosis. Diagnosis of atelectasis. First of all, we use several instrumental tests: CT scan, oximetry, ultrasound of the thorax, and bronchoscopy. This slide is demonstrating imaging, X-ray, plain, frontal, and lateral imagings, and we can find out direct signs of atelectasis. First of all, we can see displacement of interlobar fissures, crowding together of pulmonary vessels, and crowded air bronchograms. This is clinical case, 67-year-old woman with incidental right middle lobe atelectasis. And next instrumental test, this is spirometry. Spirometry can help us to assess the ventilation, and ventilation rates are mixed with a large area of lung damage, restrictive disorders predominant. Patients, they usually have decreased vital capacity and obstruction is observed in approximately 20% of the patients, and the incidence is the index of bronchial patency are reduced. But in this case, patients, they have decreased forced expiration velocity 1. So let's make conclusion. Pulmonary tissue seal syndrome may be manifestation of different diseases. The chest X-ray and CT imaging are the most common tests using to diagnose this syndrome, and every doctor of different specialties must be able to recognize pulmonary tissue seal syndrome. Early and timely detection of the syndrome can significantly help to improve outcome of patients. Thank you very much for attention.